what is this ICCM strategy? An equity-focused strategy attempting to increase access to care for children with these 3 illnesses, malaria, pneumonia, and diarrhea, in rural communities, so poor rural communities in low-income countries, promoted by WHO and UNICEF, scaled up through community health workers across Africa, and many countries are using this ICCM approach and community health workers. And in 2010, Uganda adapted the strategy for use here. In Uganda, we also have some private sector implementation that I will talk about. So community health workers are trained to use diagnostic tests and appropriate medicines to diagnose and manage malaria, pneumonia, and diarrhea. So in 2010, Uganda rolled out an ICCM implementation. And the objective of this work done in 2017 and 18 was to determine the extent of implementation, so up to the end of 2018, extent of implementation of the integrated community case management approach or strategy in Uganda, as well as enablers, challenges, and priorities for scale-up. Using a qualitative case study research approach that utilized visits to implementation stations or partners, key informant interviews, so 15 visits to implementing partners, 15 implementing partners and key informants with them, and a desk review looking at policy documents, partner reports, peer-reviewed literature, etc., with a list of about 52 that we were directly speaking to the topic. And I present this based on the themes that we find, so looking at the context of the policy, content, process, extent of implementation, challenges, enablers, opportunities for scale-up, priorities, and some recommendations. So what is the content? Is that this policy is not standalone. It developed from the integrated management of childhood illnesses as the community component of the integrated management, which had a facility component and a community component. And in Uganda, we utilize lay volunteer community health workers who are not paid, and they diagnose, treat, and provide referrals and manage children. Objectives of the national strategy for ICCM in Uganda are that really 80% of children receive appropriate treatment timely within 24 hours. Referral is prompt, 0 stockouts. Management of severe illness is also well done. The health workers are well trained, and they are out in the field and working appropriately. What instruments exist in Uganda? We have a lot of tools to support ICCM implementation. Implementation guide, implementation plans, training manuals, information, education material, reporting tools, and the strategy has been really taken up in key documents and highlighting the use of integrated community case management for increasing access to coverage. So our national health strategy, our plans for reproductive, maternal, neonatal, child and adolescent health, what we call a sharpened plan, malaria reduction strategy plans, these really highlight integrated community case management as a key strategy to use. So as I'll take you through that. As we do this policy analysis, what is really happening? What is the context? What is the history? Looking 25 years back, what have we been doing nationally in relation to case management, community case management? And this all started, like I said, with integrated management of childhood illnesses, 1995. By 2000 and 2003-04, we have a national rollout scaled up in all districts in Uganda. Then we start to do evaluations, really, what's happening with this integrated community case management strategy supported by WHO. So evaluations show low quality of care, lack of community access, the community component of integrated management missing, etc. So then we get to literally what's happening between 2005 and 2008 or 2010 is now the integrated community case management drive comes up with all these strategies from the global level, and the countries and our country taking up taking up ICCM into the child survival strategy, the village health team strategy, etc. So now we are really launching implementation of ICCM in Uganda. And as we do that, finally, in 2017, we have a new strategy, a community health extension worker strategy that is supposed to complement these volunteer community health workers. And we'll talk about that and what it means for implementation and scale up. And so how did ICCM come onto the policy agenda is really countries failing to meet their MDG targets for child health. There was a bit of worry that MDG targets will not be met, but also based on that, strong WHO UNICEF support for Uganda and for countries to take up this policy. So this is really the context and the process, and it was really partner-led by these international agencies and adapted locally. So I move into really results. And since 2010, almost 10 years down the road, how have we done? What is the extent of implementation of this community health worker strategy in Uganda? And it's about 58%, depending on, but in 2018, districts keep increasing in Uganda, but coverage is about 50 to 60% coverage. And there's private sector implementation that I'm going to talk about. Nearly 10 years down the road, no evaluations yet, but only process evaluations. What is happening with the number of treatments, access, utilization of health facilities, and etc. So there's need for a proper evaluation. This map is showing coverage. I said about 58%, but it's really these dark spots where there's ICCM coverage. The lighter spots, all these stars are showing some sort of private sector utilization of integrated community case management strategy using the private sector. This is happening in like one sub-county, a couple of villages, and not national, not in the whole district. So the dark spots are really the districts, full districts implementing the strategy. And the rest are much smaller implementation. So that's what the picture looks like. What do we find are enablers of this rollout? So it's about 10 years now. So existing policy instruments, a lot of guidelines, reporting tools, etc. Many of these are supporting the process. The coordination mechanism from central to district level, it is there, it is weak, needs improving, but there is a system of coordination. And then these community health workers who are actually volunteering and available, and their communities are supporting them. There's this issue of creative financing for integrated community case management, which is through Global Fund, a malaria channel that is really trying to integrate more its financing of fever in children. And then I'll talk about private sector inclusion as I started already. So these are enablers that we find. What is happening to really support this scale-up of integrated community case management strategy? But there are a lot of challenges. One is that the funding is all mainly donor or partner dependent. All those dark stars, full implementation in districts is UNICEF, or now Global Fund is funding about nearly 40 districts. But still, while it's going to the national pool, I'm calling all this, external funding, and local contribution is only about 16% to this funding. And next is changing policies. This community health extension worker policy that was the strategy introduced in 2017 really came initially poised to to replace the volunteer community health workers, but there was just no possibility and no funding to roll out such a strategy to pay all the community health worker. And so implementing partners who were providing external funding literally became completely destabilized when you start saying, all right, your work is no longer, we are using a different cadre, a different approach. So there was a bit of confusion. It has been cleared up to now, but in the 2 years, over the last 2 years that I was looking into this policy, there was a lot of unease and destabilization of partners. Biggest challenge also is because of lack of committed funding, weak supplies, frequent stockouts, and reporting is low, thus with only about 20% of the community health workers reporting. and due to unsustainable funding, weak supervision of these people. So some quotations, which I'll not go through many of them, but there is no public sector financing, mainly implementing partners. And some of these interventions are very good designs and strategies, but they lack funding. Commodities are the biggest issue. If they're always lacking, you really can't treat children without commodities. At the district level, there's no committees. There's need for a focal person and a committee, a need for an MOU to understand. So people are working, implementing partners are out in the field. There's no good organization of this. And the issue of the existing system taking up or accepting most significant barrier was acceptability of ICCM by health workers and biostatisticians who looked at it as a parallel program and didn't think they needed to report or handle the data that comes, and either needed to be paid separately because these were funded by donors. So in summary, strong enablers include strong support from the international community, funding coming in through Global Fund, the policies and the documents and tools that exist, but lack of government funding are huge challenges, lack of commodities, changing, confusing policies, etc. And then I talk a bit about opportunities and some recommendations, but we saw a lot of sports where the private sector is implementing in small pockets, and there's evidence of use of private sector models through drug shops where 60% of people seek care and children. And these the BRAC and living goods are if their work can be consolidated in like a whole district, etc., there is opportunity to utilize the private sector and evidence that goes with it. So this work is really showing the priority areas really that we need to look into for scaling up is increased government contribution to this community health system, strengthening the central and district level coordination and data collection so that the data can actually be utilized. So in conclusion, we have partial implementation 10 years down the road of the ICCM strategy with many enablers, but challenges as well. And the recommendations are to improve coordination, promote national ownership and funding, ensure commodities are available, strengthen reporting, and operational research and evaluation of these strategies. Thank you very much. Thank you so much.